Well, welcome, everybody.
All right, welcome everybody. Yes, I echo Peter's sentiment. My name is Lindsay Brown from Beyond Clean, and I'd like to thank you for joining us for this collaborative webinar between Beyond Clean and Censis Technologies. If you haven't joined us for a Beyond Clean virtual event, I'd like to call your attention to a couple of features. On your screen, you will find a list of resources for today's talk. And included in those resources are links to some sterile processing surveys, which you will hear more about in today's presentation. There's a question and answers tool on the lower left-hand side of your screen. You can submit questions that you have for our speaker today throughout the presentation. And those questions will be addressed at the end during the question and answer portion of the presentation. In a year like 2020, any leader who wants to go alone may not go far. More than ever before, to go together is the only way to go. And leaders with an understanding of the power of the collective will collect the accolades. Leaders with an understanding of the power of team will experience true teamwork. And leaders with an understanding of the strength of many will know what it means to be stronger together. I am so excited and honored to introduce our speaker today. There are few more creatively disruptive voices in the sterile processing industry today than Beyond Clean's Chief Medical Officer, Dr. Peter Nichol. Dr. Nichol is a pediatric surgeon and the medical director of surgical services at American Family Children's Hospital in Madison, Wisconsin. Dr. Nichol will be leading us in a unique discussion about human error, cost savings, and the future of sterile processing. So without further ado, I'd like to introduce Dr. Peter Nichol.
Lindsay, thank you. I want you to know that my mother paid her to say all of those things, but she didn't know that she's going to end in the part about beyond disruption. I was just very disruptive as a kid in general. So the title of this talk is Adjacency and the Future of Sterile Processing. And adjacency is a word I like to throw around a lot, because what it means is you borrow ideas from one space and apply them in another. It's like Picasso said, good artists borrow, great artists steal. So, my journey began about 3.5 years ago into sterile processing because there were some problems with one of my orthopedic surgeons having bone fragments on hands 3 separate times in the span of 2 weeks. And there was a lot of hand-waving that occurred on the part of our hospital leadership. And I can paraphrase a quote. I couldn't find the quote. I lost it. But one of our chief medical officer said, well, this is a safety issue. And until we all recognize this is a safety issue, we all talk about this, nothing's ever going to get better. And that sort of set me on the road to engaging in this whole process. And it really has been an eye-opening experience, I would say. So I have a couple disclosures. Obviously, Chief Medical Officer Beyond Clean, and I do consulting for Beyond Clean. I am a pediatric surgeon by training, and I am the Director of Surgical Services for the OR at the American Family Children's Hospital in Madison, Wisconsin. So learning objectives here are to define the 3 major areas within a sterile processing facility that are losing money. You should be able to identify these after this talk. Be able to apply fundamental rates of human error to healthcare tasks and calculate their risk based on level of complexity, and identify the one task performed by sterile processing technicians that has the greatest risk of variability and error. So this is Sandra Doctor. She's the Associate Dean of Health Education at Madison College. Before that, she was the Associate Dean of Manufacturing, Engineering, and Robotics. And very early on in the whole process of exploring sterile processing, I asked her to come down and walk through our facilities. Now, this is actually not a picture of our facility. This is a very nice facility. I don't know where this is. This is not what our sterile processing facility looks like in our adult and children's hospital. And her comment after she walked out of that 2-hour tour was, oh my God, this is an absolute mess. This should be organized like high-end manufacturing, and it is not. And these poor people who are working in this are under a huge amount of stress. So I initially didn't know what she meant by that, but this led me on a journey around exploring high-end manufacturing and had a number of conversations with her and other leaders in other fields. And like most of healthcare, we have not leveraged existing technology to really improve healthcare, and we've not really leveraged existing technology to improve sterile processing. And so I'm going to talk about the opportunities around that, generally and broadly, taking technologies that already exist in different spaces and applying them in sterile processing. You add to this problem that it's not a well-organized space in general in most places. This is pretty pervasive across the United States. And you add to that hospitals really don't want to acknowledge that this is a problem. The people in the trenches know it's a problem. But if hospitals are aware of it, they don't fully comprehend its complexity, or they think they can fix it themselves, or they think it's just an HR problem, we'll just throw more people at it, or they're willing to accept it as the price of doing business. Either way, it's in the basement and no one can see it, so why worry about it? Well, this is why, because sooner or later it's going to come back and bite you in the derriere. And this is from the Detroit Free Press and the Denver Post about lawsuits that were filed against medical centers because of contaminated instruments. And there are any number of these in the news all throughout the year. So you can't just keep it in the basement of a hospital. So my journey of 1,000 miles began with one step because someone really made me angry with all their hand waving, in this case, the chief medical officer. And like I said, there was a quote about, we have to talk about this and recognize this is a problem, and until we can do that, it won't get better. Well, talking about it is not a strategy. Hope is not a strategy. Pretending it is not a problem is not a strategy. And, to get the hospital leadership to really start paying attention to this stuff, I figured they got everybody vying for their attention, all the woe is me stuff. You got to come up with a business case about how they're losing an obscene amount of money because they don't have the space properly organized. So that's what we did. That's what I did. And I can tell you, of course, we knew this going in, that the current state of SPD, sterile processing, is that it would be littered with waste, contributing to a rising cost of labor, supplies, delays, and errors. And the question was, how much waste? So I looked at 2 hospitals that are connected by a bridge in our system. There's actually 7 hospitals in our system, but the 2 in Madison proper, share a sterile processing space. And you have an adult hospital that's inpatient, outpatient, and ambulatory procedures. You have a children's hospital that does all those things. They do scopes at both places. So really good, complex mix of cases. Lots of opportunities for waste, I might say. So, between the 2 hospitals, there's between 19,000 and 21,000 cases a year. This has been a bit of a down year because of COVID. On average, they are handling about 600 pans of instruments a day between the 2 facilities. And there's about 100 instruments per pan on average. So we're talking about 60,000 instruments flowing through this space every single day. And 3 domains of waste and sterile processing that we identify are the following: HR, turnover, overtime, contracted FTEs or travelers; 2, the re-sterilizing of unused instruments; and 3, the impact on OR capacities via delays due to instruments. So employee turnover is a big problem. And, you look at the literature, they say it costs an institution about $45,000 to replace a sterile processing technician. One of the people in Beyond Clean's done a lot more work on this, and it's probably closer to $90,000 in total costs. But we'll go with a lower number. We have 10 FTEs that need to be replaced every year. That's $450,000 going right out the door right there because you don't have a stable workforce. So because you don't have a stable workforce, and because the workforce is getting stressed, you have to go hire travelers to work 12 weeks at a clip. And the annualized FTE for each one of them is $95,000, $96,000. So another $700,000 in costs. And then, the majority of people are working overtime, forced overtime or elective overtime because of the work shortages. It's another almost $300,000. So right there, HR problems, you got $1.4 million in waste because you don't have a stable workforce. And there's a multitude of reasons for that, and I'll touch on that a little bit later. But then we looked at the cost of unused instruments, and we got some pretty good numbers and estimates across a number of service lines. And this is even after they went through pan reduction, where the service line champions met with the surgeons, they went through the pans, decided what they didn't need, and threw that stuff out. They're using about 20 to 25% of the instruments in the pans. So about 100 instruments per tray. If you're familiar with Virginia Mason, they did a study on this about 5 or 6 years ago, and they calculated the cost to be about 77 cents per instrument to reprocess. If you talk to Sean Flynn, it's probably closer to $2 at Stanford. Other places have reported 53 cents an instrument. Either way, it's not cheap. And 75% conservatively are not used in these pans. So that's pretty easy math. 600 pans a day for your elective days, $77 a pan. You have 75% that are unused. You have 194 elective OR days in a year. That's about almost $7 million. Now you're running totals up to $8 million. Now you got eyeballs on this. I mean, this is a lot of money. And if you ask a healthcare system to build out to pay for this, rather than just cut the cost to the bottom line, it's not cheap. Now, our hospital has a remarkable 3.8% operating margins. Most hospitals don't. They're like 0.5 to 1%. We have a 40% collection rate. Most hospitals and healthcare systems don't. They're closer to 20 or 30%. Okay. Now, you calculated fixed costs here, which are in Pareto principle, it's a little bit smaller than you probably would calculate. Say we have $100 million in fixed costs needed to make per year for net revenue. Okay, so if we were to make up for this $8 million, we'd have to spend, $100 million to grow out of it, which means that because our charges, we collect 40%, now we got to increase our gross charges by about $224 million. Now, that's a lot of money. My pediatric surgery group probably has gross charges of $10 million a year. Okay, I mean, you'd have to build another hospital to pay for all this, or build a ton of clinics and increase your referral patterns. And this is in a robust healthcare market that's highly competitive. You're not going to be able to do this. You can't build your way out of this waste. So time and capacity are measurable. They are important. They are not as easy a cost to measure as the number of instruments are flowing or cycling through your system or your HR costs. But we can make pretty good calculations on this, and we've done this twice. And there are several types of delays that occur. A really simple one is that you end up with instruments pans getting opened up that are contaminated and not recognized. They're opened up with other pans, and all of a sudden you realize the back table's got this one contaminated pan. You got to break everything down, and that results in a delay. Now, an operating room minute at my children's hospital is about $110 a minute. At the adult hospital next door, it's $153 a minute. So this is kind of mind-boggling, we had about 111 of these events in 1 year, one calendar year. We do about 7,000 cases at the children's hospital. The average length of time delay worked out to be, I think it was about 20 or 25 minutes or so. And at $110 a minute, we had it was more than 20, it was more like 50 minutes per event. Because you got to break everything down, set everything back up. We ended up losing 6,270 minutes in capacities just with this alone. At $110 a minute, it was close to $700,000. Same thing with the adult hospital, because we were able to extrapolate our numbers to them and make a calculation. They do 12,000 cases a year. If you have the same rate that's occurring in those 12,000 cases, which you do because we share a sterile processing space, and you have this at $153 a minute for OR time, $1.6 million. Now we're up to $10.5 million in waste for these two hospitals. And then this is probably much more profound in terms of impact, but the capacity loss because of instrument delays. So we went and spoke to all the different OR teams, service line champions. They said, listen, I have at least one instrument delay per OR every single day in the middle of the case. And some take 30 minutes to fix. Sometimes the surgeon just says, you know what, I'll use a different instrument. Estimated the average length of time of these was about 8 minutes. Well, if you take the weighted average of an OR minute between our children's hospital and our adult hospital, it's $143 per minute. So one delay per room, 38 ORs, 194 days, 8 minutes. This is $8.4 million. We've gone back and looked at this a second time just in the children's OR, and we're finding that at least 1/3 of the cases, so well over 2,000 cases, are being impacted So 1 in every 3 cases is being impacted by an instrument delay. And it's significant. And we're actually recording only a 20th of those because it's up to the nurses to record that when that happens. Okay, so now our running total is almost $19 million in our healthcare system around waste. This comes out to, for 19,000 cases, $994 per case, all $1,000 per case. So we can play with these numbers and extrapolate them as a proxy for what else is going on in the country. So our system has a pretty good representative case mix, and almost $1,000 a case. And there's 51 million surgical cases performed in the U.S. annually. You march out these numbers, and it is a almost $51 billion problem. And this does not include the cost of instrument repairs or instrument replacement. This does not include the cost of lawsuits that result out of infections acquired because of contaminated or dirty instruments, or the cost of dealing with the surgical site infections that result from those and providing care for those people, since the hospitals have to eat that bill as well. So this number is deliberately low, but this represents in total probably about 5 to 7% of all hospital waste in the country. So there are rules for industry to solve this, because what we have right now, I can't even call it a cottage industry in terms of how hospitals are dealing with it. It's more like each hospital tries to come up with their own resources and solutions, but nobody's really doing a very good job. It's kind of like you have a bunch of individual craftsmen trying to fix this problem, and none of them are really talking to each other. So there's opportunities around bioburden, around instrument decay, patterns of decay, lost instruments. We don't track instruments on an individual level. I mean, there are technologies that are coming online with this, but there's not. We haven't been doing this. The incorrect instruments ending up in the pans, instruments beyond they're being used beyond their lifespan, even if they don't have significant decay. Are they safe to use? Poor maintenance, poor recall, poor retrieval, OR delays, and this happens in every OR every day in every hospital. There's not a hospital that is not touched by this. And this is not going to be systemically addressed by hospitals. Hospitals think they can fix this. They are not going to be able to fix this because of all the technologies I'm going to talk about that need to be implemented to do this. You really need to do this with industry partners. So the real fundamental problem in all this, the limitation of all this, is human performance. And in the late 1990s, Lucian Lee published this paper called "To Err is Human." And he calculated that there are about 98,000 people who died every year in the United States because of medical error. In truth, that number is probably much closer to 440,000 people, based on what we know today. It's a staggering number of people. So the reason humans are error prone, I mean, I don't know the real biological reason other than we're not robots, but this has been studied, human factors analysis, and who's to study it better than the airline industry? And these numbers come from Manfred Mueller, who was, and I think still is, the head aviation safety officer for Lufthansa. And he gave a wonderful talk on this about 15 years ago. And if you give a human being a simple task and you have them repeat it over and over and over, they will make a mistake every 5 minutes. And if you give them a complex task and you have them repeat it over and over and over, they'll make a mistake every 90 seconds. And if you give them that complex task and now you stress them, so midday, all the pans are coming back, sterile processing. Now time is ticking by. And you're getting phone calls, I need this pan, I need this pan. Stress is going up, there's noise, there's heat, people are getting tired, they've been on their feet for 5 or 6 hours by this point. All those complex tasks now become complex tasks under stress. They make a mistake every 30 seconds. And these are really the limits of human performance. There's the rare individual who can extend beyond that, like a Wayne Gretzky, who scored all of his goals at the end of his 30-second shift because everybody else was getting tired. But by and large, these are immutable numbers for human beings. Yet you're not going to be able to take the human being out of this. So we have to figure out, how do we improve the environment so the human being performs better? Now, what's interesting about this is you can play some really impressive games, number games with this stuff. And I'm not going to say that every error is significant, but if you, in a single hospital shift for a 200 to 299 bed hospital, you have about 300 people in an 8-hour shift. If they're doing tasks pretty much continuously during those 8 hours, and half of those tasks are simple, and half are complex, and half of the complex ones are under stress, okay, they're going to make 110,000 errors every shift. Think about that. They have 200 patients in the hospital in their capacity, or 300 in their capacity. That's 120 million errors per year. So, a hospital like that on average has about 12,000 admissions a year. That means that there's 10,000 cumulative errors per patient. Now, some of these, it probably isn't quite this high, but let's say it's 1,000. Who cares? That's extraordinarily high. And they may not be that significant. It might be, an error in the electronic medical record around spelling when you're doing the history part of it, history physical note. Or it could be a typo for a medication that gets transmitted, that error gets transmitted, and then you give the wrong medication. Any number of things, leaving stuff out of the history and physical exam. All those things, they can add up. So this is a staggering number. And this is exactly why we need to start applying manufacturing standards in healthcare and in sterile processing. So what are human beings doing in the current state of SPD? Well, they're actually doing a lot of things. We measured the number of steps that are involved from when an instrument leaves a surgeon's hand and goes in through sterile processing and comes back through and gets handed to the surgeon. And it's somewhere between about 100 and 112 steps. A handful of those are really high stress, high complexity steps. So, you count instruments in the OR, you assemble the instruments back in the pans before you send them out of the OR to SPD, you decontaminate them, they get inspected, you wash them, you inspect them, they get reassembled in the trays get wrapped, they go into the sterilizer, you recall the tray, you then store the trays, then you retrieve the trays, then you transport the trays. Every single one of these steps has a risk for error. And this is a fraction of all of them. So, if you use the same numbers, 50% simple, 50% complex, and 25%, half the complex ones are under duress, and you have a fixed number of employees, you can make a calculation of your error rate per pan. Okay, now, the one number I don't have in here is, what is the error rate of a simple task under stress? I don't have a number for how frequently an error occurs. But let's say you have 27 people per shift, which is what we have, and every one of them is error prone, and you assume this 50, 25, 25 split, and they're constantly doing tasks, you'll have 9,900 errors every 8 hours, which if you're handling 200 pans in those 8 hours, comes out to 50 errors per pan. Now, they're not all significant, but there is certainly a significant leak rate through that affects the pans. So this was one of my learning objectives. You should now be able to take those numbers from Manfred Mueller and Lufthansa and look at the number of people working and make a rough estimate of the number of tasks and they're doing and performing and calculate error rate. So clearly we need to improve the precision of all processes. And we cannot solve our problems with the same thinking we used that created them, or the same processes. So this is a quote from Albert Einstein, obviously. And you really can't make a silk purse out of sows here. You cannot automate a fundamentally error-prone, inefficient process and expect a better, more efficient results. So, the fundamental flaws of the system are, number one, human error. But you have to consider the environment itself is very stressful because it's a restricted environment. Oftentimes it's shoehorned into some small space in the basement of a hospital with low ceilings, poor lighting, really loud, high humidity, poor ventilation. There's a complete lack of informatics. This is a fundamental flaw in the system. There is information flows everywhere in sterile processing. It boggles the mind if you know that, and you go down there. It makes your head spin. There is a cultural resignation across hospitals that, look, it is what it is. This is what people get paid to do this. It's what everybody else is doing. We're not going to fix it. There's really a failure to use return on investment tools to address this issue. And hospitals really do not have the resources to operationalize this transformative change. So these are the other fundamental flaws. with the system. I mean, to do this, to really do it, you have to do it right. And you have to measure all the things that I've already made estimations on in terms of costs, time, error rates, et cetera. And then you need to find technologies to optimize these processes. Test them and make sure they actually can do what they're supposed to do, validate them, and show that you've improved the steps in these processes through this optimization. And ultimately, we really need to establish new definitions of best practice based on the data around inspection, inventory design, inventory availability, inventory size. I mean, we could contract our inventories if we could get people to just use what they really need in the OR, get the surgeons to cooperate with that and give them informatics. We need to have best practices for doing risk assessment of the inventory and whether the instruments are safe, both in terms of bioburden and performance. Location, where they're located. There are great recall systems available, library recall systems available not being applied, and tracking instrument lifespan. Of all these steps that I've talked about, inspection is the one that is the most prone to error. It is the highest risk for error. So that was one of your learning objectives. Please remember that. So we have to minimize human error, and because you can't build a better human. So there really is a role for industry and markets to establish an expectation for the right instruments to the right surgeon for the right patient every single time. And setting measurable goals. I mean, you really, with informatics, you should be able within 5 to 10 years and with some cultural change, get surgeons to really have smaller pans so they're using 90 to 95% of the instruments on the pans. This will result in shorter count times. We can actually measure this. And assembly times, at the pans, reassembly times, the pans in the ORs, which will help reduce turnover times. Once you get down to single instrument tracking throughout the whole life cycle of an instrument being reprocessed, you shouldn't have any missing instruments. And you should be able to establish criteria for bioburden. This is actually a fairly heavy lift, but should be doable within 10 years. So we have no bioburden. Or at least, stuff that's really beyond detection. It's not biologically significant bioburden. And we should be able to do all this and have it not result in delays in the OR because the instruments won't be missing. So putting the existing pieces together, you need to practice adjacency, right? You have to, good artists borrow, great artists steal. Pablo Picasso. One of my very best friends is the former CEO of a healthcare system in northwestern Wisconsin. When he took over as CEO, this is 20 years ago, he went right over to the Train Company, which manufactures air conditioning units, and he picked off their top 2 or 3 engineering leaders and made them senior vice presidents in his healthcare system and told them to get to work, to bring in new ideas, because the physicians didn't have any ideas about how to improve the systems. So that's practicing adjacency, borrowing something else or someone else from another space, applying it in your space. So inspection, easily the highest risk step in the whole process. Occurs at least 4 times in each instrument cycle. You're looking for bioburden. You're trying to figure out the instrument's intact. You're trying to figure out whether you have the correct instrument, whether all the instruments are in the pans, right? And there are limitations to this. Variable lighting, variable magnification, ergonomics. I mean, it's like the way these tables are set up is painful. And they do this for hours and hours and hours. And then you have the variable eyesight of the people who are doing this. And variable experience of being able to identify what is significant, what is an error, what is a damaged instrument, what is not a damaged instrument, what is something that really looks like bioburden that we have to address. And then you change the time of the day and you have variable stress, which gives them variable time to do this. And there's variability within each individual and how fast they can and efficiently inspect stuff. So inspection is, again, the key of most highest risk step in all sterile processing. So really what you need to do is, what they're doing in industry is consider other visualization technologies that can be paired with AI and informatics so that you can start delineating parameters for bioburden. Now that's not easy. Having a visual parameter for bioburden depends on you correlating that with culturing stuff off of instruments and growing it in the lab to seeing what the risk is. But I will tell you, there was just a publication about 2 months ago where they cultured little pellets of bacteria in space for 2 or 3 years on the International Space Station. And these pellets were 50 to 100 microns across, max. They brought them back to Earth 2 years or 3 years later. 4% of the bacteria were still active and viable inside those pellets. either being in space, high radiation environment, harsh environment, 150 below zero, or having a sun blasting on you. Unbelievable. So bioburden is a big problem. Trying to culture everything and test it is not feasible. You're going to have visualization proxies for that. Delineate patterns of breakdown of simple and complex instruments, because you can't always see this. And there's a huge amount of information flows around this where you start having predictive analytics around when is an instrument starting to reach the end of its life cycle. Fleet and instrument identity and inventory management. So if you can use visualization technologies both within the OR and in sterile processing, and you can track individual instruments, you'll know where they are in the entire cycle of being reprocessed. That helps your inventory a lot. You also can use them to record case-specific, surgeon-specific behaviors, and then present the surgeon with that data so that they aren't saying, well, I want my 200 instruments no matter what, because I never know what's going to happen. Well, the last 300 times you've done this laparoscopic hernia repair, this is what you've used. We're happy to keep a separate pan in sterile core for you, but we're not going to open it up. Here's your data. If you have a better solution, great, tell us. Otherwise, we'll let the administrators go at you and start pounding you about how much variance there is in your cases. So of course, this has to be paired with AI. AI is very interesting. AI has to be taught. You have to know what to teach it. A human being has to do this because AI can't learn alone by itself. If you give it something it's never seen before, it just kind of goes berserk. But if you give it millions of iterations of a single instrument pattern, it can learn that stuff very, very quickly. And you can use this for algorithms for instrument identification, bioburden identification, instrument decay patterns, pan completion and verification, both in the SPD space and in the ORs. And of course, this all bleeds into informatics. So you take all this visualization data and you feed it into the informatics machine, and you can predict surgeon behavior. And it also gives you a lot of agility with your fleet in that you can, once you have all this data, you can anticipate what your replacement rates are for certain types of instruments, and you can budget this. It makes it much easier than this whole capital budget thing we do every year, which is a total free-for-all. It would not be acceptable in high-end manufacturing, industrial manufacturing world at all. And it also enables you to offline problematic instruments before they become a problem. So what else do we need to think about? Well, we need to think green and sustainable. Hospitals are the number 7, if they were a country, they'd be the 7th largest country as a contributor to climate change, greenhouse emitting gases. So this plays into efficiencies, cost avoidance, efficacy. And those who jump on this early have the advantage of being a good global citizen and marketing that good global citizenship to their advantage. As I think we're seeing this is becoming much more important to the millennials who are coming up, who are going to be purchasing healthcare and are generally healthy and be having young families. So it's going to be kind of like Intel Inside. If you have this and you're green, people will feel good about going to your healthcare system. And ORs are the biggest contributor to greenhouse gases and pollution in the hospitals, and 46% of them. I'm sorry, back up. I'll back up here a second. 46% of the waste, the carbon footprinting, comes from having instruments you don't use. So if you can get rid of the instruments you don't use, the reusable instruments, then you're going to cut into this carbon footprint by 50%. Pretty significant. Great benefits here. Integration with EMR. Not only can you have surgeon-specific behaviors, but if the surgeon's doing, 200 or 300 inguinal hernia repairs a year, and there's variation in body habitus, there may be some variation in the instruments that person uses. So you can use those informatics, pull those out of EMR for the patient, and say, tell the surgeon, for this case, you're most likely going to need these instruments because of this patient's body habitus. So this is all, this information flow, all these informatics are very valuable. And so you also need to think about cybersecurity, because what you don't want to have happen is somebody come in and ransomware your hospital or your SPD department and charge you $500,000 to get all the informatics. Now you have your surgeons with their specific pans for the specific types of patients sort of allocated out. All that suddenly stops and you're over a barrel. So you need to protect this with cybersecurity, and this has to be built in from the beginning so you don't get ransomware. So we have to think about those things because we live in a dangerous world with greedy people who have already thought about all this stuff. In terms of selling it, administrators, they want predictable costs, they want less variability. They want fewer instruments, they want a smaller inventory, and they want improved efficiencies, okay? And I put this picture in here because it looks like this physician is really, really annoyed. And physicians get really annoyed with administrators. They really do. So the surgeons in particular want autonomy. They want to do the operation the way they feel they're most comfortable. Remember, surgeons are not all built the same. They have different body habituses, different heights, different ergonomic needs, agilities, et cetera, et cetera. So you can really use informatics to give them the instruments they need and reduce the variance around instruments they don't use and don't need to reduce the pan size and resolve this conflict with administrators who want everybody to do the operation the exact same way, which is not a realistic expectation. And you can show the surgeons the data, ideally, of what they use, and then tell them, go to your administrator and tell them that your pan sizes, you got 15 instruments per pan, and tell them to get off your back. So I guess I still haven't really answered, how do we improve the human? And so I've spent a lot of time talking to Sandy Doctor about all this. And she said, you can never take the human being out of this space. You have to use the technology to elevate the human. So the workforce in sterile processing, I think you already know this, is really an at-risk population with regards to socioeconomics and also education. Yes. So before I launch into this, all this data was from, I'm going to present now, is from a series of surveys that we had people fill out back in May. Those surveys sites have been reopened for today for the 360 who decided to join us for this, this webinar. So if you've not taken these surveys, they're on socioeconomic status, they're on educational background, and they're on health and safety in the sterile processing space. This data has been very, very revealing for us, and it was a beyond clean endeavor. So, so if you have not taken these surveys, which I'm going to talk about the data from those in a minute, I would love it if you would sign up and take all three of them. So, okay. So 74% of you, please do this. So this was really, really striking to me. And I knew that there were going to be problems around this, but people are in this very high stress job and they're very poorly resourced around this. And then they're not paid enough. They really, really aren't. And, you know, a lot of people leave and take jobs in the restaurant business where they go clean dishes, do other things because of the stress that they carry around with them, knowing that they make a mistake, it's going to affect a human being. Right? I mean, the surgeon doesn't usually touch the patient. The instruments touch the patient. So it is just absolutely galling to me what people are paid in this space. It is not ethically, morally justifiable on any level. But just to illustrate how bad it is only when you get to people making over $31 an hour that the majority of them actually have $2,000 in the bank in savings. And this is a minority of the people that answer this survey were able to say, yeah, I got $2,000 in the bank. And to drive the point home even further, credit card debt, 69% of respondents in these surveys had credit card debt. Now, the amount on average is $8,700. So the differential, if I were to, you know, the differential here is, I don't know what the average amount of savings is, but it's under $2,000 for this whole population. Most people are walking around in debt, probably to the tune of $7,000. And those who aren't still are probably, those who have at least $2,000 in the bank still are probably in debt. How the hell are people supposed to work in an environment like this if they can't get paid enough to live? The people that work in our space can't live in the town that they work in because the cost of living is so high. And here they are performing these incredibly important tasks without really a whole lot of support, educational or otherwise. They're not being paid. How are they supposed to do this? How do hospitals allow this to happen? They're actually contributing to the poverty of their own workforce. And the number one risk to health is poverty. It's crazy. Education. So this is what I've had a lot of time talking to Sandy Doctor about, is how do we really build educational structure around this workforce? It is desperately needed. And once it's there, it really starts making the argument for why there's value to pay people more in this space, okay? But if you break all this down, there's a smattering all over the place of levels of education. Actually, very few people have formal education in sterile processing. Just under 50% have some formal post-high school training in sterile processing out the workforce that respond to these surveys, so about 900 people. On average, the length of training they had in sterile processing was 7.2 months, okay? And most of them are going through programs where it's part of surgical tech programs at technical schools. It is not a program that's specifically designed towards sterile processing and the needs there, and what are going to be clearly significant needs as you get informatics, visualization technology, and all this stuff embedded into this space. So you have a socioeconomically stressed workforce. They're undertrained because there's not opportunities for them to get training. Now, what's really interesting is, and I don't have this data to present to you, is the people working in this space are very thirsty for knowledge. They will spend hours trying to find answers to questions that come up in the workspace. They will do their own research online. They'll go to good sources for information and try and read up on stuff. But it's not given to them. It's not provided. There's not a structure nationally for this workforce. And you really need it for informatics, for water chemistry, microbiology, biofilm, leadership, education. You need all this stuff. So, you know, this is, again, a population that in the next 10 years, if industry gets into this, is going to undergo a major transformation. You have to have the educational structure in place in order for that transformation to occur effectively. So there clearly is an educational mandate to advance the human and establish a clear, robust post-secondary educational pathway with apprenticeships, exposure to multiple work domains in sterile processing. That way, the cost of entry is actually kind of low because they're already working their way through college and getting paid in these apprenticeships. So you bring down that entry, the cost of the activation and energy to get into college. Give them train. These machines that are used in sterile processing, sterilization machines are very complex. They have to undergo troubleshooting. They break down frequently. So giving them formal training in this rather than just on-the-job training. Additional training regarding biology, systems engineering, informatics, water chemistry, et cetera, so that when people go through these 1 or 2 year programs, they're really ready to go the first day on the job, and you aren't offlining your best sterile processing technician to train them for 6 months with variable results. And eventually, logically, you're going to have to develop additional pathways of education around this because you're going to need educators, you're going to need leaders. So, a 10-year goal, if I was talking industry, which I kind of am here, to get to 6 Sigma, you want to get to 6 Sigma, have safe surgery in every hour, every time. So this is essentially uncharted territory. We're pre-Adam Smith. We're not even at the pin factory level of industrial manufacturing. We're way before Henry Ford, okay? We're in uncharted territory. But the beauty of all that is that the best way to predict the future is to create it, Abraham Lincoln. So with that, I'll answer any questions.
All right, wonderful. We have had some great questions come through, so I am going to get right into it. The first question says, what classes or courses in college do you suggest to start with for sterile processing professionals?
Well, I would definitely get a microbiology course. And I'd ask them specifically about biofilms, although you probably want to know a little bit about virology at this point, so microbiology. I think chemistry would be valuable, and enough so that even if they don't teach you about water chemistries, or maybe they do, that you can get an adequate level of knowledge and you can start asking critical questions around water chemistries and your water systems. It's been a long time since I've been to college, but anything on informatics would be valuable, really. And I think beyond that, systems engineering They have courses in that. I think human factors analysis, if you can get a course in that, that'd be great, because that'll tell you a lot about human error, and it'll open up your eyes to where you're going to see things that need to be improved within your own space.
Okay. Wonderful. This next question says, in your study, did you look at how to help the OR put instruments back into the correct pans? No,
we have not looked at that yet. I've got several teams that are going to be studying this once this COVID thing settles down in Wisconsin. So we're going to look at, the first thing we're going to look at is measure the real rate of instrument errors, like how many delays per OR per day in the children's hospital. And we're going to do that over a span of about 4 to 6 months. And then from that, we're going to be, once we have that number, we're also going to start looking at, what you have to do is you have to be able to know what's supposed to be in the pans when they leave and what happens when they arrive at sterile processing. So measuring those two areas, make sure the pans are complete, that would be the next step. We've not looked at that yet. What's next?
Next question says, let's see, how about the future of the sterile processing technicians with high school degrees only? What suggestions do you have for that population?
Well, I think if, we're trying to get so I think you got people who are going to be really good at this stuff that don't need further education. They're going to get grandfathered in. You already have certification, certifying bodies for this kind of stuff. But I think we're going to have more technical schools in the next 10 years really focusing on this. And I think, there'll be paid apprenticeships. So like I said, the cost of entering the college for that is going to be pretty minimal, because you're going to get paid to go to school. I would do that. I mean, I would do that. We have something similar happened with nursing, where a number of the hospitals started getting away from LPNs and moving to RNs, going from 2-year to 4-year degree. And a lot of the nurses at that point were LPNs decided to go back and get those extra 2 years of schooling in. And I think it pays benefits.
Okay. What is a good way in starting this process to identify unused instruments without slowing down turnover?
Yeah, so the HR problem here is really the problem. Like, you really need technologies that are fast that can measure this stuff accurately. So even if you have people doing it, and there are companies that do this stuff, there's still a human error rate, and they're only going to do a certain sampling of the cases. You really need to be able to do this continuously. So this is where technologies really need to be implemented. I totally understand the question, but the only way to do it right now is to have human beings deployed in the OR, counting what gets used and what doesn't get used, or having the surgeon beg, the scrubs and the nurses to keep track of everything and do it on their own. So, it doesn't take that much time to do it, but there's the error of forgetting to do it, and then there's the error of not including the right instruments or including instruments that you don't use. So the best way to do it is to implement technology so it doesn't interfere with the workflow.
Okay. Speaking of technology, are you aware of any technologies that use AI to help techs reduce errors in things like tray assembly or inspection or anything like that?
No, there's a number that are being developed, but I've not seen anything that's available in the marketplace yet.
Okay. We recently actually had a webinar with a company called RST Automation, and they're taking a look at that and producing more technologies related to that. So if anyone's interested in looking for more information, certainly reach out to them. Another question: how can you get administration to help leadership develop themselves and their staff and buy into developing the department as a whole?
Oh, God. So this is so hard. All right, I'm going to go a little bit off script here. And I hope this doesn't wind up somewhere in a public domain where I'll get fired. But I think, the best, so to begin with, you have to have really good leadership, right? And you have to have a healthcare system that is not complacent. And there's a handful of those around the country. But if they're complacent and they're bureaucratic, there's not a lot you're going to be able to do. The best healthcare system I've ever been around is Gunderson Health in La Crosse, Wisconsin. And that's where they brought in all these, senior engineers, from the train company to come in as senior vice presidents at Gunderson Health. And that group of leaders didn't really have any office space. They were forced to go out and be amongst everybody all the time and find problems. Now, if you're in an environment where all the leaders sit in offices and go to meetings all day, I don't think a lot's going to happen. There's not much you can do about it. The best you can do is try and make a business case and see if they pay attention. That's what I did. Because they will pay attention to dollars. And then the next question they'll ask is, well, can we fix it ourselves or not? And depending on their level of intellectual honesty, not moral honesty, but intellectual honesty about this, they're probably going to realize we're not going to be very good at fixing this. We don't have the resources. They'll actually dive into it and look at it in depth and realize the magnitude of the problem. But it's a challenge. I'm not going to lie to you. We've been battling this battle at the University of Wisconsin now for the better part of 2 years. And I believe now we finally have an approval simply on the HR side to try and stabilize the workforce by increasing the amount of pay. But it's taken 2 years. 2 years. Shouldn't take that long. So, this gets back to the bigger theme about how healthcare really needs to be set up like high-end manufacturing, because then you have people really thinking about this stuff all the time and continually, implementing process improvement and asking these questions. That doesn't happen right now in healthcare. People are pretty complacent in terms of leadership in healthcare around these kind of issues. So it's hard. So I guess my advice would be make a business case and get as high up into the leadership hierarchy as you can and show them your business case and be passionate. That's the best anybody can do.
Okay. This next question says, do you see feasibility of off-site reprocessing centers?
I absolutely do. And I think, okay, so that's a great question. And again, even the best leaders are going to tell you we can fix this problem ourselves, okay? My state has 65 critical access hospitals. They perform surgeries there. And even emergency surgeries, there's a limited palette of the types of emergency surgeries they perform. I mean, it's pretty predictable what they do. Each one of them probably has 1 or 2 people who run sterile processing, who've been there for 30 or 35 years, who know everybody's preferences, who walk around with all the informatics in their brain about what all their surgeons want, right? And the day that they get sick or the day they retire or the day they go on vacation, the whole system falls apart because you're relying on human beings. There's an absolute need for those hospitals to have a significant portion of their stuff being off-site. You're always going to have some embedded on-site management. Now, whether that's done by industry or not, I don't know. But I think off-site has great potential. I just think it's going to take time for the cultural shift to occur, for people to accept, particularly surgeons and physicians, accept this is the way to do it. What they want to know is that they're not going to be caught, because of an ice storm without any instruments and people come to the hospital. Although they think about that, but the truth is nobody drives in the hospital in the middle of the ice storm to have an elective surgery. That just doesn't happen. And if it's a hurricane that hits and the hospital gets flooded out or the sterile processing site gets flooded out, they're both going to get flooded out. So it's going to be a disaster either way. But I think there's great potential for off-site sterile processing.
Okay. This question is related to loaner trays. Do you require vendors to include lists of instruments when they drop off pans at your facility?
Oh boy. I don't know if we require it. I know that things have tightened up considerably around loaner trays in the last year or two. I just don't know the answer to that. I'm sorry.
All right, this question. Do you think the sterile processing department could ever go fully automated?
Nope. You're always going to need human beings. You're always going to need human beings because you will always need new information, okay? And even if you have, so robots aren't going to do all this stuff. It's just not possible. I mean, think about this. I've been to instrument manufacturing plants where I asked this question and they like laughed at me. They're like, have you ever seen a Castro Viejo? Let me show you one. Hang on. I'll show you. I think I have one. I thought I had one. Hang on. No, I don't know where it is. So Castro Viejo is a needle driver, not like this, but it's one you actually pinch, right? Those are $3,000 a piece. That's what they sell for. It takes a human being 2 hours to file, polish, and assemble a Castro Viejo. They're very delicate, right? 2 hours, craftsman. You're not going to fully automate sterile processing. You're not. It's not going to happen. You still need human beings. You're going to still need human beings to teach the machines. There's always going to be more information to learn. You're going to need human beings. There's just going to be better jobs.
Okay. Is there a governing body that you think can assist with increasing pay scale for sterile processing?
Well, I would say, I wish we had better relationship. I wish we had a better view on unions in this country. And I wish unions were like the unions in Germany, where they understand that certain jobs will go away and they got to be continually moving forward and innovating to recognize where they can create more jobs rather than just trying to maintain the status quo. But I think the real answer there is unions. I don't know if that's a governing body, but I think that's your best way to advocate for more pay. And you'll have a much bigger platform with a branding and advertising budget that really can conduct advocacy on your behalf.
There was also a question that came through asking if your department was union or non-union.
Non-union.
Okay. Did you look at ways to determine adequate backup of instruments? I often see technicians put a substandard instrument back in a pan because of inadequate backup, and they can't afford to have a set out of circulation.
Right. So we don't have a system for that. And it's an absolute mess. I mean, there's no instrument tracking. You know, stuff goes missing all the time. There's some drawers downstairs. Everybody knows to look in those drawers, or certain people know to look in those drawers for instruments. No, we don't have a backup. We don't.
Okay. Do you believe that state certifications should be mandated?
You mean other workers? Or are you talking about
for sterile processing technicians?
Oh, I don't know if I have the right experience to comment on that. I guess what I would say is I think it's much more important that states start demanding education from the technical schools for this and demand that the hospitals support programs like this. Because I think certification, because then you can really test people and you can, get the right people on the bus to train and you can start getting some outcomes measures in place. I don't know that I see that you have those opportunities with certification, mandating certification. Okay. I guess I'm sidestepping the question, but I'm more in favor of mandating technical education in this area and that hospitals pay a living wage, that they really pay like it's a high-tech job. And I think you do that, it'll make things a lot better for everybody, including the patients.
All right. How can you get administration to help leadership develop themselves and their staff and buy into developing the department as a whole?
Repeat that question again, Lindsay.
Sure. And you have a unique perspective on this because as a surgeon, you probably have a very different relationship with your administrators than frontline sterile processing technicians. So I'm curious to know this as an SPD tech myself, what your answer is. It says, how can we get administration to help leadership develop themselves and their staff and buy into developing the department as a whole?
So when you're saying leadership, you're talking about leadership of SPD?
Correct.
Okay, that was why I was confused. Well, I do have a unique perspective on this. So SPD leadership can be very problematic in some places. It can be wonderful in other places. I I think what administration has to do is it actually has to survey the workforce and see if the workforce feels like they're being supported and educated and have the resources they have or not. That's what I encourage administration to do. And then based on that data, if you have people who are not satisfied working in that space and don't feel properly resourced and supported, then you go to leadership and say, you know, you've been here a long time and we know you care deeply about this, but this is how your employees feel about your leadership. And this is where you need help. And we're going to put you on a performance improvement plan in the next 6 months, and we'll give you additional resources to help you with this. And then we're going to resurvey your employees in 6 months and see where you're at. And if you've not improved things, then we're going to get a different leader. That's what I would do.
So to go a little bit farther with this question, is there any sort of silver bullet or language that can be used as a department leader to get the attention of administration and have them actually start, I don't know, so listening to needs, et cetera?
You're asking me the opposite question now.
Right.
So I think you make the business argument.
Okay.
You say, here's the error rates, here's the number of delays, get some data on this, and it's pretty easy to figure out what your hour minute costs are. And you just tell them, look, you know, and look at your cost of repairing and replacing instruments. I mean, I don't know what percentage of surgical instruments, but I was told this last year we spent $23 million on replacing broken and lost instruments or repairing them. $23 million. Now,
wow.
Let's say it's just $5 million. Who cares? That's a staggering number, right? So the business case is always the best case to get administrators to pay attention to leaders.
Okay. Peter, I'm going to end with this last question. As a surgeon, how would you improve the relationship between OR and SPD?
If it were up to me, I would make all my surgical residents go spend 2 days in SPD. I would make all my surgeons take a tour of SPD. And then I would, if I were the leader, I'd say, all right, you need to meet on a monthly basis at least. I would have SPD organize itself vertically, and have a series of vertical columns for each service line, and designate a service line leader within SPD to meet with the service line champion from the ORs, and make sure those two are talking on a regular basis, because they kind of do it anyways, but to formalize the process and make sure the surgeon is part of that process. So they're fully aware of what's going on. They should know what's happening to their instruments. You know, they sit and bitch and complain about, I want my instruments, but they actually don't really care about the condition of the instruments. They just want their big pants. You know what I'm saying? Like they don't think about it granularly in that kind of detail about what's happening to those instruments when they're not here. How are they being managed?
Yep. And I said last question, but I'm actually going to make this one a last question because I think it will benefit a lot of people to know, how are you actually getting your error rate? Are you auditing, or is there a different process that you're going through at your facility?
Well, right now, so you saw the calculated error rates from Manfred Mueller. What we're going to do around instrument errors is I've got a team of about 10 nursing students that we're going to deploy in the ORs for a span of about 6 months and have them observe cases and delays and find out whether they're instrument delays or not. Because we know only about a 20th of the delays are getting reported, but we want to actually get the real number. So that's how we're looking at errors. So that'll capture bioburden, that'll capture missing instruments. That's the majority of the lost capacities we talk about.
Okay, great. Dr. Nichol, it has been a sincere pleasure listening to you, learning from you. And for everyone who is still tuned in, whether you're a frontline technician, a department leader, or an industry advocate, hopefully this discussion provided you with some key insights into what is really right and to what is really wrong with our industry, along with some encouragement for how to improve it both today, tomorrow, and beyond. In about an hour, everyone will receive an email that will have a link to this session on demand, along with a link to access the session survey and download your CE certificate. You can watch this session again, you can reference it, you can share it with your colleagues, and you can also click on the CE icon at the bottom of your screen right now to access that survey. We would love your feedback about this session.
Take the survey, please.
Yes.
We're going to help.
Absolutely, yes.
Participate in this survey, the more robust the data. Okay,
Yes.
we want eyeballs on this. Okay, if each one of you could contact one person, contacts another person, and we can do this ghost to ghost hookup thing, and get another 1,000, respondees. Okay, we have much more robust data that I can then put in front of leaders. And this stuff's all going to get published anyways when I actually have some time to write. But it's really important.
Yes, and the surveys that Peter's referencing are the surveys that you can actually click on right on your screen right now in the downloadable resources form. Over the past 6 months, we've enjoyed learning together and hearing your stories of true grit in these challenging times. As the True Grit, True You series comes to an end, we are grateful for your participation and your hope. We hope that you've learned something new every time you attended one of these webinars, opened the True Grit app through Censis Technologies, and read a CE article or interacted with one of their subject matter experts. While the True Grit series is ending at the end of the year, Censis Technologies wants you to keep your eye out for more ways to continue your education with Censis in 2021. True Grit, True We, True You. On behalf of Beyond Clean and in partnership with Censis Technologies, we thank you for once again joining us today. And as always, we encourage you to keep fighting dirty. We'll see you all next time.